record. And here we go. Welcome everybody to a Tuesday edition of Clinical Problem Solvers. It is my distinct pleasure to welcome in everybody and also to introduce my co-discussant, the great and wonderful Youssef Saklawi. And today we also have a case by the great Hans. So I'll ask Youssef to unmute and introduce himself, and then Hans also to say a few words about what he's up to nowadays.
Yeah, thank you, Ravi. I'm Youssef. I'm a CP Solvers member for the past almost a year and a half now. Just graduated residency a few months ago, started hospital medicine career. Excited to be here. Ravi, I haven't discussed with you enough. I think we've only discussed a few times, so I'm excited to co-discuss with you.
And Hans, how
Hans, do you
goes
want to go
things?
next?
Yes, I think I'm already known. I'm presently a volunteer here in Huntsville, in Muskoka, both in Huntsville and in Bracebridge. So at home for a while.
Brilliant, brilliant. And Youssef, how goes things with the transition to attending life?
So far, so good. I wish I had somebody to attest my notes or review my orders and check everything, but it's a different feeling.
Excellent, excellent. And I think, let's see, Sosan, how are you? You going to be scribing today?
Hi, yes, I'll be scribing.
Okay, brilliant. And what have you been up to other than applying?
Taking piano lessons.
Oh, wow. Okay. I will be doing something. I will let you know at some point. Learning a couple of instruments. So sit tight for those. Stay, I guess, sit tight for that one. That'll be coming shortly. I have to acquire a couple of instruments and we'll see. And Gerardo, are you doing teaching points today?
Hello, everyone. Yes, I'm doing teaching points today.
And how goes things with you? How you been?
Yeah, very well. I just came back from doing exercise, so I might appear a little bit sweaty.
Brilliant, brilliant. Okay, shall we get started with the case?
Okay, I have my microphone on. So today's case was actually one of the people that I know over here. Today's case is a 43-year-old man who lives in Connecticut. And he presented himself to our rounds with a chief complaint of recurrent episodes of hives, accompanied with vomiting, cramping epigastric pain, and watery, non-bloody stools. And that is the first aliquot, the chief complaint.
Wow, what an aliquot there. Youssef, you want to take a first stab at this?
Yeah, thank you so much, Hans. Very rich aliquot. I hear we have a 43-year-old gentleman presenting for hives, vomiting, and non-bloody stools. And when I first hear about this, I first consider the hives, and I want to know about the duration of those hives. Are they coming on and off? Are they coming on for like less than 24 hours or more than 24 hours? And I want to consider whether this is actually urticarial or not urticarial. And the initial branch point is the duration and the frequency of these hives. But we see here that it's also associated with systemic symptoms. So it's not just the skin that's involved, maybe some GI abnormalities, and trying to localize the lesion into which pathway is it? Is it the pathway of mast cells? Is it the pathway of angioedema? Or is it the pathway of other GI endocrine producing tumors? These are the general branch points that I'm considering. In terms of Connecticut itself, so far I will not make a connection this early unless I hear a connection to food or anything like that. But otherwise, I'm still very broad. What are you thinking, Ravi?
Yeah, it's quite interesting. I think the hives, if I was trying to frame this and concoct a problem representation, I think pretty much you will encompass everything here, but a lot of this vomiting, cramping, epigastric pain could be non-specific. Maybe the hives are secondary to whatever process is going on in the abdomen. But at this point, duration is key. Are we dealing with something that was just recent? And also, I would like to know if this is something that patients are rather young, so I would anticipate recurrence of this, say hives before to other exposure of antigens. And if there's been other episodes of stools, diarrheal stools like this, if there is a intestinal disorder here. I mean, something that comes to mind with skin and intestine, celiac disease is something I may deploy at this point early as a diagnosis, but I still want to remain sort of non-biased and not committing to a diagnosis at this point. But yeah, if I had to use a framework at this point, what would I concentrate on? I don't know yet. I think I need more information, because are these intestinal complaints, are they truly the center of gravity here, or are they passengers along with this complaint of, like you said, you went down this immunologic pathway? Is that where we need to invest our cognitive energy? I'm not sure at this point, but let's get some more information. Back to you, Hans.
Yes. Then the history of present illness. Over the past year, our patient has experienced or reports recurrent episodes of hives, nausea, vomiting, cramping, epigastric pain with watery non-bloody stools. Everything seems to come together. The patient, or he cannot pinpoint any triggers that he suspects the symptoms could be related to his diet. He's not sure about that. He also notices there are no alleviating factors, such as hot showers. Later in the history, we will learn that he likes marijuana, such as in cannabis hemesis syndrome. And he also notices that proton pump inhibitors are only mildly, if not at all, helpful. The symptoms improve somewhat, so he says, with Gravol, which is dimenhydrinate and antihistamine. Sometimes the symptoms stay away for weeks and he feels totally normal, himself again. The patient denies any voice changes, swelling of the throat. He denies bloating, greasy or floating stools, shortness of breath, wheezing, chest pain, melena. He also denies fresh blood in the stool or recent antibiotic use. And that would be aliquot number 1. Or, yeah.
I guess I'll start with this. So you sort of expanded the landscape here with, I guess, the same symptoms, but now we have a few other associated features that a few meds were tried, and they did alleviate somewhat of these symptoms, so namely the skin findings here. So the treatment for, like Youssef has kind of mentioned, with angioedema or hives, what kind of, I guess, associations can you have? So you have to think about the allergic associations, then the non-allergic associations, the triggers. You mentioned triggers, so that is a key feature as well. So what could be causing it? And then if the patient has sought medical advice or seen an allergist immunologist before, we don't know if there was any skin testing or allergy testing done, but the patient did respond to medications. So certain medications that you can give, in this case, like antihistamines were given, H2 blockers can be given, steroids, a little bit more aggressive, but at this point, if that will be something that you could try once you confirm the diagnosis. I don't think we have a high enough pretest probability at this point to initiate testing. So I think antihistamines are relatively benign, and we can start those and try to see if that alleviates the symptoms of the patient coming in with. Regarding the triggers, though, so you said there was nothing really triggering this. If I think, let me go through. So yeah, I can't pinpoint any triggers. So triggers, certain triggers could be going to certain environmental places, exposure to certain scenarios, even stress could bring on things, cold or hot exposures. Is there also any signal of autoimmune phenomena? Because this could be related to autoimmune disease, or even endocrinopathies. So things like thyroid disease, certain autoimmune phenomena, lupus could be associated with something like this. And I think also if there, I mean, simply put, allergic causes, is there something that could be identified, like maybe use of or change of laundry detergent could also be something that could be associated with it. But at this point, yeah, I'm not sure. What do you think, Youssef?
I think I haven't been to this space like too frequently, and like I mentioned earlier, like I was thinking the broad buckets of could this be like something mast cell degranulation going in, or is this some neuroendocrine tumor like going out, like Mark phrased it in the chat. But the I'm trying to think that besides lab testing, what are ways that we can do, or what are tests or questions we can ask to discriminate between the two or differentiate, and what are the discriminating features in this case? And things that I think of is that if there's like involvement of the mucosa, then I consider things like angioedema, for example. If there is a predominant diarrheal phenotype that could potentially be neuroendocrine, although I think it's hard to discriminate. I would want to ask about symptoms related to like pheochromocytoma, like things related to like tachycardia, tachypnea, things like that. And then the age, I don't know if that alone can discriminate between the factors. So I think maybe after the physical exam and before the labs, we could potentially have small breakout rooms and discuss how would everyone think about this problem and how would they solve it, because I think it's a good area to think about.
Back to you, Hans.
Okay, so aliquot 2 is the past medical history and physical exam. So past medical history, there is no past medical history. Patient is not on any medication. Family history is not known or not relevant for us. Social history. He works as a real estate agent, and he describes his profession as being very stressful, and he also finds it very difficult to sleep more than 6 hours at night. The patient feels much relief by exercising regularly, and he enjoys hiking and all kinds of outdoor activities, which allow him to combine his spare time enjoyment with his profession, as he sees the cottages over here where he lives. The patient also admitted to smoking marijuana recreationally, only recreationally, 1 joint per week, and he drinks alcohol occasionally. For muscle aches and soreness that he does experience ever so often after vigorous exercise, he uses an anti-inflammatory pill a few times per week. So that is our southwest corner, and the next would be the physical exam. And we start with the vitals. Okay, the vitals. Temperature is 96.6, which is 37 degrees in our measurement. Blood pressure 118/62. Heart rate is 62. Respiration 18. And SO2 99, room air. His weight was 74 kilograms. General, he is alert and in no distress. HEENT. No scleral icterus was seen. Moist mucous membranes. No palpable lymph nodes. Heart exam. There was a regular rate and rhythm. No rubs, no gallops, and no murmurs. Abdominal exam on the day that we saw him was normal. Completely, with bowel sounds and no tenderness. Lung exam, clear to auscultation bilaterally. The extremities, and no rashes and no edema. So the physical exam on the day that we saw the patient was completely normal. And that was aliquot number 2, and the next will be the lab values.
Thank you so much, Hans. It sounds like here we have like an intermittent disorder, and it's intermittent that in the sense that in between the episodes, sounds like the patient was not having an episode right now, and their exam was completely normal. So I don't think that helps us like gather more information or discriminate further. What do you think, Ravi? Is this a good time to create breakout rooms for everyone to discuss and then come back? That way, people can think about their differential, what they want to order.
Yeah, I think we're pretty early. That would be a great idea. Do you know how to make the breakout rooms?
Definitely.
Okay, let's pause. Okay, great. Welcome back, everybody. In regards to what was being discussed in the rooms, we'll ask for anybody from room 1. I think we had Carl, Parissa, Philip. If any of you are able to unmute and share your thoughts, what were you discussing in room 1 in regards to this case? All right, if not, we'll move on to room 2. And we had Adam or Mariana, Patricia, Lucas, if any of you are able to unmute and share your thoughts.
Yeah, we talked about some of the ideas that came up before, like we talked about allergies, sensitivities, IgE mediated syndromes, for example. Also, eosinophilic syndromes was mentioned as well. And I think of eosinophilic syndromes, most affected are the things exposed to the environment, so your lungs, your GI, and your skin. So we have a few hits there. So I find it, I think that could be interesting to entertain. I know in the chat we talked about also in the room like mast cell syndromes, and some of those actually can be triggered by stress or NSAIDs or things like that as well, which we find in this story. And we also talked about infection, considering infections, but that the timeline here doesn't really fit very easily, and most it's a pretty atypical timeline presentation for most infections, although we always try to think about that, whether that could be the case as well. But we just got a little bit into tests. We talked about checking things associated with that. So checking for eosinophils, IgE levels, and then digging more into the history.
Absolutely, yeah, great. I think you mentioned there's something also, we don't have a signature in the lungs, which would be associated with that. I would anticipate some wheezing along with these episodes, but we're not seeing that. We're not seeing the hemodynamic instability as well, or tachycardia during these episodes, or hypotension, syncope. So we have a normal exam, but then this is also a snapshot in time. What if he had those abnormalities during these episodes? So you just kind of have to wonder, but I appreciate your input. Some wonderful things that you mentioned there. Definitely we're going to integrate those into our differentials. Room 3, anybody? Anmol, Gerardo, Soham, Hamdi, anybody want to unmute and share your thoughts?
I can share what we
Oh,
talked
great.
about.
Thank you.
Yeah, so we were just discussing that when we think about watery stools or watery non-bloody stools in general, we have a lot big differentials, but then it is accompanied by hives. So that is what is making it more tricky. And then we were discussing that there must be a unifying mechanism because it is all happening simultaneously. Whenever it happens, all the symptoms come together. So there must be a unifying mechanism causing both the GI symptoms as well as the skin symptoms. And then we were also discussing about the IgE hypersensitivity, the conditions which may be causing the both of the symptoms. And then we were discussing that there must be a trigger, even if it's an external trigger or an internal trigger causing the symptoms. And then that's pretty much I think we were discussing. And we touched upon celiac disease as well to be the one of the an aside cause if we just focus on the watery non-bloody stools. So we could not come to a final diagnosis, but that's how we were just discussing about the pathophysiology of the case.
Thank you, Anmol. Some great thoughts too, which are helping to support a few of the hypotheses there. And great, yeah, I think you mentioned the celiac disease, which we were thinking as well. So yeah, I'm not sure, but I think the testing, like Adam had mentioned, testing will be key to see CBC chemistry and then getting a differential and getting the IgE levels to see if one of these could be, one of our hypotheses could be supported. And then I'll go to room 4. I think we have a few minutes. Yeah, Christian, Jasdeep, Vinicius. Any input you have for this case?
Yeah, so we're just talking about like the possible hypersensitivity reactions and how we can like maybe thinking about it and differentiate it. Other things about we try to dissecate about the systemic mastocytosis and correlate them with leukemia and maybe other possible paraneoplastic syndromes. But we got to a point that yeah, if we consider any paraneoplastic syndromes can do anything, and this is hard to dissect. And we truly think that, as you said, the testing will be key, but I don't even know how to proceed with what I'm asking for right now. So yeah, that's it.
Oh, Vinicius, I just love what you mentioned. Like we earlier on, Youssef had mentioned this is a space we haven't explored in a while, and so we're all in this together. In that we're not sure, we may need to improve our knowledge in this. So this is a great case to really explore the landscape of hypersensitivity reaction. So I appreciate your honesty with your not knowing what to order next. So let's see with we'll ask the next room maybe before we go on to the next aliquot. We have some time. We'll pick the last room. So Mengyu, Taha, Yasmin, we have quite a number of rooms, but I'll ask room 7 if they have any input before we go to the next aliquot.
So we were also trying to figure out what was triggering this whole scenario. So we discussed that if it was something related to food, it would have presented much earlier in his life. But then again, we also discussed that there are some tics that can induce these sort of inflammatory reactions late in life. But we also couldn't really decide or lock our thoughts on any one point. So
Absolutely, yeah, I agree. Absolutely agree with that. Thank you for the input. Okay, let's should we go on to the next aliquot? I think the labs may shine some light on trying to clear up what is going on. So Hans, back to you.
Then
I think I agree. Oh, sorry. I was just gonna say I agree with you, Ravi. It sounds like from the case we wanna look for signals. We're gonna look for the eosinophils initially. We're considering maybe NSAID induced like mastocytosis could be an option, but to diagnose that we would wanna like avoid NSAID, and then if an episode occurs, get a tryptase level. I guess that's where we're at right at this point, and that's I think what I would order if I were seeing this patient in clinic.
Okay, then I continue with the labs. We have our starting off with CBC. The WBC count, the white blood count, was 5,000 with a normal differential. Hemoglobin 14, MCV 82, platelet 300,000. So everything normal on this. Then the chemistry, that was normal as well. So sodium on the day that the patient was seen and those labs were done, sodium was 135, potassium 4, glucose was 100 milligram per deciliter, A1C was 5.0, creatinine 0.9, BUN was 15 milligram per deciliter. So everything within normal range. This routine lab then made us look at more specific labs. So the liver function test, it turned out to be normal as well. AST was 18, ALT was 25, ALK phos was 60, total bilirubin was less than 0.2 milligram per deciliter, albumin was 4.0, so the liver function test was normal as well. The next step was, let's look at lipase, and that turned out to be normal. It was 49 units per liter, and the normal range was 8 to 51. And then the usual exams in the emergency department when somebody has diarrhea or complains about diarrhea, stool over and parasites, negative, including Giardia, Cryptosporidium antigens, then a Clostridium difficile test, and toxin, all of them negative. C. difficile later on was done with PCR, and that turned out negative as well. Immunoglobulin A level, IgA, was 272, the normal range, 47 to 310, so that was normal too. Our idea was maybe look at celiac disease. So tissue transglutaminase IgA antibody was normal. Fecal calprotectin, just to see whether ulcerative colitis and Crohn's disease would be there. That turned out to be negative too, 110. C-reactive protein was 0.41. The normal range is 0 to 4.9. ESR was 9, and the normal range is less than 15. And the TSH was done as well, and that was normal too. And this concludes aliport number 3, and aliport number 4 will be imaging.
Oh, wow. The labs are very perplexing, but essentially normal. You've actually ruled out a large number of different things that we were considering. So, I mean, I don't get a sense of inflammation pretty much here. We're talking about all these fancy auto-inflammatory conditions and so on. So I think we have to go back to the drawing board and think about what's common is common, and think about, what did this patient say? Sometimes the patient will tell you exactly what is going on, what the trigger could be. Hans mentioned initially there were no triggers, but the patient's like saying this could be related to food. So what kind of foods could this be? A food intolerance? I don't see anything like with the CBC, patient's not even showing signs of dehydration, no tachycardia, no hypertension, in spite of having this diarrhea. Electrolytes are fine also, although the sodium is 1 under normal, 136. Bicarb, if patient was having diarrhea, you would have a non-ANGAP metabolic acidosis. Liver enzymes are okay. You don't even have pre-renal azotemia with significant dehydration. So I think with the fecal calprotectin, you can essentially, you're not getting a signature of inflammation in the bowel, and CRP and ESR are negative. So I think if I had to think about trigger, what is the patient's diet? Is this happening right after he's eating? Think about if there's just a plain allergic reaction to wine, cheese, or anything like that he may be taking. And what do you think, Youssef, at this point?
Yeah, I think this is reassuring. If I saw this patient, we don't see any anemia, we don't see any iron deficiency, which is good, which makes me reassured that this is not like a GI-based disorder. We don't see any electrolyte abnormalities, which is usually a marker of severe diarrhea. So, and we don't see any markers of inflammation either. So this confirms that this is an intermittent disorder, and the intermittent disorder could be secondary to either mast cells degranulating or different exposures. And I like you mentioned the possible exposures, which include either NSAIDs or the food allergy. I think both of these are very plausible. And I think in both these conditions, I would like either an ordered tryptase level, have the patient avoid the food, avoid the NSAIDs, and then see if this recurs. And then if this recurs, I would want to get a blood draw like right after. I don't know if I would have gotten imaging at this point, Ravi. Would you have gotten imaging?
Oh, that is a fantastic question. So this is then sort of stepping into your domain of management reasoning, right? So something that is near and dear to your heart. And you would have to ask yourself, or you have to question yourself, is it worth to spend that money? And do you have a good enough question to order imaging here? I'm really, like, you pretty much laid it out, that there's nothing that is an alarm finding here to get acute imaging, and like some right now get imaging for the abdomen. The exam is pretty much benign here. Regarding the other hypothesis that you had, this mast cell activating syndrome, I would kind of like to see other things. Again, the hemodynamics, when you have that much of mast cells overacting, they spill over into other systems, right? The skin, the GI, also the lungs. We're not seeing any signal in the lungs. Usually patient would have wheezing and so on. So syncope, shock even. Patients can come with severe shock. I'm not getting that sensation here also, or a flavor of that here. But then again, I don't have a lot of experience. If I recall mast cell activating syndrome, I did have one patient that I did a consult on, but they were stable at that point. But this is definitely very exciting, something that's stretching the limit of our knowledge, and I'm ready to learn a lot more with the next aliquot. Any other thoughts here with Youssef?
I think I agree with you. I think if the initial workup is negative, my next step would be imaging, like they're all mentioning, because initially we said, could this be like a neuroendocrine tumor? But I think I would start with avoidance, and then maybe a tryptase level, and then if those are negative, I would get imaging. But I think it's just a matter of like practice base and where we're seeing this patient.
That's a great point. Say you're in the clinic with this patient, so it's not like you can just grab the imaging. You would have to send the patient out. Are they stable enough to go get imaging, follow up, and then look at the imaging? But if this patient's admitted to the hospital, you could get imaging within hours. So I think the patient's stable enough. If you're admitting this patient in the hospital, you have time, because the patient's not exhibiting alarm symptoms, to get that CT to help you answer this question. The question is there something, like you mentioned, in the abdomen that could be causing this presentation? Back to you, Hans, for the next aliquot.
Yes, the kind of imaging that was done was an EGD, and the finding was basically normal. That is, a normal esophagus and stomach with erythematous duodenopathy, so a slight swelling and redness of the mucosa in the esophagus and stomach. The colonoscopy was done, and it was normal. In particular, random colon biopsies were negative for microscopic colitis. Then random gastric biopsies were done, and they were all negative for H. pylori. A duodenal biopsy was done, and it revealed focal cryptitis with acute inflammation of the surface epithelium and a mild flattening of the villi. There was no increase in lymphocytic infiltration of the epithelium, and that concludes the imaging that was done. CT abdomen was not done.
What do you think, Youssef?
I think this is like a pathologic finding, which I don't think I could throw a lot of my information about. Like, I'm not sure this we don't see any eosinophils, we don't see any lymphocytes, so that's reassuring. But I'm not sure if we have like one spot with like focal acute cryptitis. Is that alone a signal for any particular disorder? I know the flattening of the villi is like the classical description for some disorders, but I don't know if we just find it once, is that like significant enough or not? I'm not sure. So I would want to ask the specialist, like, is this significant enough for you to think of like celiac disease, although the serologies are negative, or to think of celiac sprue, for example? What are you thinking?
Yeah, I for villus atrophy, I don't know enough like what could cause it. Essentially, why would you have villus atrophy? Inflammation is one. The other is, if you're not taking anything enterally, then you have that sort of use it or lose it phenomena. So our patients that are MPO, we don't want to keep them MPO for too long, because otherwise they will suffer villus atrophy. The surface area of the colon will suffer this atrophic response. So inflammation is key. Although what's interesting, there's no signal that all these labs that we always use to try and figure out if there is, if to discern if there is inflammation or not, are essentially negative. So we have inflammation, like you said, in a certain spot that isn't calling in all the inflammatory mediators like, hey, come on, let's have a party here in the colon and have increase in white count, differential, certain cells, and so on. So I think the pathology of this specimen that they've got is probably going to give us the answer. Microscopic colitis, I know you won't have any surface or abnormalities of the surface architecture, so that essentially has been ruled out. But I like to know in the next aliquot what Hans has in store for us.
Okay, then the last aliquot will reveal the diagnosis, because basically all tests were negative and didn't show any pathology, but the patient mentioned a possible relationship to food and the coincidence of hives and gastrointestinal symptoms made us then think he should keep a very, very detailed food diary. So we asked the patient to do that and come back. And the patient did that. And indeed, he came back with a very detailed food diary where he noticed when do the symptoms occur and when is he completely fine, as on the day that he presented to the emergency department or to the clinic. And the diary showed that the patient's symptoms or his symptoms often occur about 3 hours after he eats red meat. And it was actually mentioned in the chat very early. That is, the patient has developed an allergy against meat. And that was a little bit flabbergasting to me, because how could somebody in his 40s all of a sudden become allergic to meat? But it all kind of fits together if we look at the patient's profession, being a lot outdoors, showing cottages to his customers and enjoying hiking in an area which is very well known to be infested with ticks. And indeed, I was really surprised that a tick bite as such from the Lone Star tick can cause alpha-gal syndrome, that is an allergy against a surface sugar molecule present on most of our meat products. And because meat is just like gluten, so prevalent in our diet, the patient, unless he is really looking out for a meat-free diet, he definitely will have those allergic reactions. So it was really completely surprising. Thank you very much for the opportunity to present this case. I thought I'd have to show it.
Wow,
Yeah,
that's
amazing
amazing.
case.
Yeah, Hans, so well presented. I think Youssef, I think in the first aliquot, the biggest thing was, like, remember I mentioned, let's tear it up and go to the basics. The patient said, is telling you it could be related to the diet. And what was in the diet? Milk, cheese, eggs, salads, fruits, vegetables, meat. So I think we needed to ask more about, is this related to meat? But very educational case. And I think we have to do a good history. Yes, I love this food diary, but also ask about certain foods if this gets worse with any of these food types. What do you think, Youssef?
Yeah, I think it's an amazing case. And the pathophysiology here is that the Lone Star tick bites into like mammals. And because the tick, when it bites into the mammals, like deer, horse, dog, it gets exposed to antigens. And then when it bites the human creates an antibody against the alpha-gal, which also cross-reacts with the meat protein that it's been exposed to as well. And the CDC released like last year a report that this is actually very underdiagnosed. It's actually more prevalent than we think it is, mostly because nobody is testing for it. And then there was a case last year where they actually created a genetically modified animal that did not have the alpha-gal. So patients with alpha-gal could like eat this food. And there's a whole podcast about it. If anybody's interested, you can just message me and I'll send it to you. But it is like a very, very interesting case. So, and I think there's also a Radio Lab episode on this. anybody's interested in podcasts. So thank you so much for bringing it, Hans. Any teaching points you wanted to share, Hans?
Actually, this one teaching point that I would like to share, apart from really we need to do when a patient comes in with gastrointestinal symptoms, we have to do a very, very thorough history. And I think we have to go into details pertaining to the diet and the lifestyle. But what I've also learned is the Lone Star tick, and it's usually not seen in our area, but climate change, as mentioned earlier in our VMRs, brings all those infectious diseases, and in this case, an allergy, which is really surprising, into our area. And this is already the second case. The first case that I saw was a really very tragic one. It was East equine encephalopathy or encephalitis, and the patient was in the end paralyzed, and he still needs special food. I think he's still on Ensure and other food supplements, slowly recovering, and we could not get the diagnosis back then. We sent the blood and the CSF to the States, where East equine encephalitis was already present, but not in Muskoka. But now I see it in Muskoka as well. And the Lone Star tick in Connecticut, which used to be further south, and it's just a matter of time until we see all these things further north in this area. So thank you very much again.
Yeah, Hans, you're absolutely right. There is a warning out, I think, in the Vermont, Maine area for people to stay indoors because of an outbreak of Eastern equine encephalitis. So that was a recent health warning that went out to people in that area. All right, and Gerardo will take it away with teaching points. Thank you.
Yeah, thank you so much, everyone, for this great case. And well, this was a case that initially was very difficult to analyze, right? Because we had a patient that had hives and GI symptoms, and we couldn't really target any possible causes that that are known to everyone, and we had a really tough time trying to analyze everything so that it could fit our illness scripts of the diseases that we know. And we started analyzing the hive, mainly the hives, which are the most distinctive symptom that the patient presented. And when we think about the hives, there are many ways in which we can analyze them. But I think that the one point that was really good to know was dividing the hives based on the pathophysiology, and it can be mast cell mediated and bradykinin mediated, which is a difference between urticarial disease versus non-urticarial diseases. And then we try to analyze the coexistence of these hives and the GI symptoms. And GI symptoms causing hives could be explained by neuroendocrine tumors, like carcinoid tumors that, due to its production of serotonin, it can have both manifestations, right? And hives causing GI symptoms could be a sign of systemic mastocytosis. And these disorders are known to be to present with sometimes with signals of organ infiltration, which was something that we were looking for in the labs, but we didn't have any signal of that. And when we see a patient that has these types of symptoms and that are not really showing any signs of inflammation or other diseases, they can very well be due to possible to triggers, right? So we should investigate those triggers. And initially, those possible triggers for GI symptoms and hives were proposed to be NSAIDs and food allergy. And well, we were analyzing a case of finally we were analyzing a case of inflammation negative, image negative, a patient with GI and urticaria, and there was in the setting of these patients, we really need to do an extensive investigation on triggers, mainly food, right? And turns out that when we investigate, when the patient was investigated for possible triggers, and the patient kept track on their diet, we found that this patient had an alpha-gal syndrome, right? And this is explained as an hypersensitivity process. And basically, the pathophysiology is that the patient some antigen, some foreign antigen from is inserted into the patient's body through a tick bite, the Lone Star tick bite, and the patient's body produces an IgE against that, and it can trigger mast cell degranulation, and it can present as a hypersensitivity reaction with the symptoms that we found on this patient. And some teaching point that Hans mentioned was that we really don't associate this insect to the particular location where this patient came from, but recent evidence is showing that the Lone Star tick is changing its habit, its typical habit due to climate change, and that is actually something that is happening a lot in different countries. I know that, for example, in my country, I know that dengue fever tended to, or usually was found only in the jungle, but right now we are having a lot of cases in the coast. So that just goes to show that this is a very important topic, and that it actually can potentially change our analysis of a lot of cases that are triggered by insects, and they can change their habit due to due to climate change, right? And well, that is everything that I could recollect, and thank you so much.
Thank you so much, Sausan, for doing the teaching points. Thank you so much, Gerardo. Good to see you. Hans, thank you for bringing this amazing case. I hope you always bring us these excellent cases for us to learn. And I hope everyone can reflect on what we learned today and generate a schema for all of these teaching points. So thank you all, and have a wonderful day.